in sub-Saharan Africa. There are 1.2 million people living with the infection in the United States, and 1 out of 7 don't even know that they're carrying it. Over 40 million people have died since the beginning of this epidemic, and studies from 2022 said that 630,000 deaths were from HIV-related complications. So we know this is a devastating infection, probably one of the most devastating to mankind. The country with the highest adult HIV prevalence globally is Swaziland, Africa, or Eswatini. And as I mentioned on Tuesday, this is where I did an elective for 1 month in OBGYN and internal medicine. And at that time, I believe it was about 40% of the population. So when you do prevalence, it's the number of people based on that population. And Swaziland is very small. It's about the size of New Jersey. It's a country, but it's about the size of New Jersey. And 40% of people during that time were HIV infected. So that's like 1 out of every 2 or 3 people was infected with the virus. They have made a lot of progress. I believe their number is now down to about 26 to 28%, but they are still the number 1 in the world. Here in the United States, poverty remains a driving force of infection, particularly in the South, where their rates of poverty are the highest. With that being said, the Northeast has a higher prevalence rate overall, likely due to dense urban populations. So you see what is number 1 up there, and you can see down on the list 1, 2, 3, 4, 5. Maryland is also in that list of new HIV diagnoses. At the end of 2022, there were said to be 31,616 people over the age of 13 in the state of Maryland with HIV. More than 23,000 of that 31 were African American. Can you guess what city had the highest rate in the state? Baltimore. One of the second, yeah, one of the 2 highest areas. Baltimore City and Prince George County were the 2 areas with the highest rates. As I mentioned, the virus does tend to affect African Americans at disproportionate rates, as well as Hispanic communities. Reasons possibly due to economic disparities, lack of access to quality health care in those groups. So we're going to talk about HIV. There are 2 types of HIV, HIV-1 and HIV-2. They are classified based on their genetic differences and characteristics of the infections. HIV-1 is probably what you're going to see. If you have a patient with HIV-1, more than likely, with HIV, they more than likely have HIV-1. That's the most common type worldwide and the most pathogenic. That is going to be the focus of the lesson. We're going to talk about HIV-2 for comparison's sake, but this focus is going to be on HIV-1. HIV-2 is seen primarily in West Africa. It is not as pathogenic, has lower transmissibility, and is less likely to progress to AIDS. This is just a resource. Remember, this is not updated, but this is basically how the HIV infects the cells, and we're going to go into each of those steps on the next slide so that you can better understand it, because that is how we determine the treatment. The life cycle of the virus itself is how the antiretroviral therapy comes to. So we're going to start with binding. So what happens? HIV enters the body through bodily fluids, semen, breast milk, coloring blood gets through. So the HIV enters, it binds to receptors on the CD4 cell, and then it basically sends a message asking the CD4 cell to let it in. Hey, let me in. And once it's allowed in, it binds or fuses. There's our fusion category next. And it dumps everything inside of it, inside the cell. So it just empties itself out. And basically at that point, HIV RNA, enzymes, things like that are dumped into that CD4 cell so that it can produce more virus. The next step is reverse transcription. In order for that RNA that was just dumped into the cell to be active, it has to be converted into DNA. So RNA is a single-stranded genetic material, DNA is a double-stranded genetic material. So that RNA wants to copy itself, so it is converted to DNA, and that is completed by an enzyme, an HIV enzyme called reverse transcriptase. The next step is integration. So now that we have that newly formed HIV DNA, it moves into the nucleus of the CD4 cell, and we know that the nucleus is our command center. So it's basically, now it's gonna tell it what to do. Another enzyme is needed to integrate that HIV DNA, and that is called integrase. So next, after integration, we move down to replication. After integration, it's now officially part of the CD4 cell. So it's combined and integrated with the nucleus. Now it's actually a part of the cell. And once it's inside of there and working functionally, it commands the cell to start making HIV proteins. And now it becomes like a host. It's a manufacturing company. It's like, oh, let's produce more. And while it's doing that, it releases these long chains of RNA, which is what we need for the virus to replicate, and proteins that contain the information on how to make it. So now we're replicating, we're making several copies. And then we're gonna go into the assembly stage, which is next. So once those long chains are released, then they need to be assembled. So they go to the edge of the cell where they're kind of lining up, getting ready to go. At this point, it's still non-infectious. Those cells are not able to cause any infection at that point. So once they're lined up and they're on the edge, that new HIV pushes itself outside of the CD4 cell, and it takes a little bit of it with it, takes some of that protective coating. And that typically is done by a process of cleaving, and that's where protease is released. Protease is another HIV enzyme that we need in order to mature the cell. So once that protease is released, then we have infectious cells. So all of this time is destroying that CD4 cell. It's not working. It's not doing what it needs to do, which is how we get to that weakened immune system. Also during this time, our immune system is trying to respond. It wants to control the virus. It's like, oh, we gotta get rid of this thing. We gotta get rid of it. So it is causing an inflammatory environment. And with that, more CD4 cells die. So now you can see we got CD4 cells dying in this process. And as a response, our body trying to really fight that virus, it's creating more inflammation, more CD4 cells that are killing themselves, self-destructing. So that CD4 cell steadily going down. Questions about how that life cycle works? So this is kind of your general overview. HIV is a retrovirus. And when we say retro, usually we need to, the DNA tells everything what to do. In this case, the RNA is telling everything. So it's retro, it's backwards. Going backwards is not working like it normally should, a virus should. It produces DNA copies that integrate into the host cell, destroys those CD4s, and impairs our immunity. So that's just your overview of everything. How is HIV transmitted? So typically through contact with bodily fluids that contain infected cells. This can be through blood, semen, vaginal secretions, breast milk, wound exudate, or skin or mucosal lesions. Usually you can't transmit HIV with saliva unless there's a lot of blood in saliva. So that is not typically a common form of transmission. There can be direct transmission through sexual intercourse if there is some type of mucosal trauma. Needle or instrument related transmission. So this is going to be sharing of needles, needle sticks. I did put a resource at the bottom in your presentation that talks about needle sticks. I believe 1 in 300. You have a 1 in 300 risk if you get a needle stick if you are not given post-exposure prophylaxis. That risk goes up to 1,500 or 1 in 1,500 risk that you might contract if you are not treated. If you are treated, your risk factors, aren't as bad. I mean, it's a really hard chance that you're gonna get, infected. Transfusion or transplant related. So you just heard in the video about, how they were doing vaccines and testing for, or doing the, how vaccines were made and what they were using and things like that. Back in 1985 is when they developed the test for HIV. And so now there's a huge screening for donors, for blood. So typically transfusions are pretty safe at this point, unless you received blood products before 1985, then you might have a problem. Then lastly, vertical transmission. This is from an infected mother to child during pregnancy, childbirth, or through breast milk. All right. So what are our risk factors? Globally, the most infections are spread through heterosexual contact. Globally, most infections are spread through heterosexual contact. In high-resource countries, such as the United States, Australia, Western Europe, the patients at highest risk tend to be men who have sex with men. In Southern Asia, it's people who inject drugs, and that includes the Philippines and Indonesia. As we mentioned earlier, there are increased rates of spread in situations revolving surrounding poverty, also sexual violence, lack of education, stigmatization, criminalization, and discrimination. All right. So we're going to talk about the stages. I have given you 3 stages. The World Health Organization has 4 stages, so you may see 2 different things. But for stage 1, this is the acute HIV infection or acute retroviral syndrome. In stage 1, HIV can present with nonspecific findings or can be asymptomatic. Many people can live with HIV for years without treatment. They aren't even aware that they have it. As we said, 1 out of 7 don't know that they are carrying the virus. For the first 10 days or so, HIV kind of stays hidden. It's impossible to detect. You can't test for it. But during that time, millions of copies are still being made. So remember how we talked about that process. It's creating those copies over and over and over. At one point, they're not infectious, but once that protease comes in and cleaves and matures the cell, then it becomes infectious. So even though they're not sick during the first 10 days after the infection, they are making millions of copies of the virus. When patients are symptomatic in this stage, it usually begins about 2 to 4 weeks after the infection. It can last 3 to 14 days. Patients might experience fever, malaise, fatigue, dermatitis, sore throat, neuralgia, lymphadenopathy. Some patients develop generalized lymphadenopathy and have no other symptoms. So if you have a patient that comes in and their lymph nodes feel swollen, but they have no other symptoms, this should be on your radar. Patients sometimes complain of just simple flu-like symptoms. During this stage, there's a high viral load. So it's a great risk of transmitting the virus at this time. There's a lot in the blood. It multiplies rapidly and spreads easily. And then there is at the bottom, it says the antigen antibody test or the nucleic acid test or NAT testing, nucleic amplification acid test, whichever one you call it, is used for diagnosis, and you'll see why in a second. During that stage. The second stage is chronic HIV. We call this asymptomatic HIV, or it can be considered clinical latency. HIV is still active and continues to multiply, but the levels of the virus are much lower. These patients may not have any HIV-related symptoms, or if they do, they could be very nonspecific. This stage can last 2 to 15 years or longer. Without treatment, chronic HIV infections usually advance to AIDS within about 10 years, but some could advance faster. Viral loads increase, CD4 counts do decrease as those viral loads continue to replicate. For those who are taking treatment, antiretroviral therapy, they may be in this stage for decades. While it's impossible to transmit HIV, while it's still possible to transmit HIV during this stage, people who take the antiretroviral therapy as prescribed and maintain undetectable viral loads have a very low possibility of transmitting the virus. Our third stage, AIDS. So AIDS is the final and most severe stage of the infection. Because HIV has severely damaged the immune system, the body cannot fight off those opportunistic infections, which we talked about several of those on Tuesday. During this stage, the CD4 count is less than 200 microliters. To be diagnosed with AIDS, the CD4 count has to be less than 200 microliters. Less than 200 microliters. These patients have a high viral load and they can still transmit the virus. Typically, during this stage, they may only survive about 3 years. CD4 count for AIDS, less than 200. For patients who are immunocompetent and healthy, your CD4 count is usually between 500 and 1500. That's for reference. 500 to 1500 is normal. But for these patients, when it goes under 200, that is considered AIDS. We went over a few of these, but here's a list of opportunistic infections, many of which are AIDS defining. Some are latent forms, so you may have them from childhood and then they reactivate later due to this weakened immune system. TB, candidiasis, we talked about on Tuesday, typically of the esophagus, trachea, bronchi, and lungs, that is AIDS defining. Now, if you get it recurrent in the mouth or vaginal candidiasis, that may still indicate that your CD4 counts are not where they need to be and put you in the AIDS stage. But typically, esophagus, trachea, bronchi, lungs, those are keys for that type of fungus. Toxoplasmosis, histoplasmosis, histo, we talked about. Cryptococcus, we talked about. CMV, we're going to talk about. Pneumocystic pneumonia, PCP, we talked about that. That's the most common cause of pneumonia in HIV patients. What do we see on their X-ray? Ground glass, yeah, infiltrates, ground glass appearance. And how do we treat them? With an antifungal? Background. Kaposi sarcoma, which is what he talked about in the video, that was the cancer caused by AIDS. You see the picture of it there. When those patients start to have those skin manifestations, that is AIDS defining as well. Kaposi's is human herpes virus 8, but it does cause cancer in AIDS patients. Last is HIV wasting syndrome. This is involuntary weight loss of more than 10%, mostly muscle mass. You'll see a picture of the gentleman at the top who is experiencing wasting syndrome. Muscles are pretty much gone. These patients also usually have to have at least 30 days of diarrhea or some type of weakness or fever to be considered wasting syndrome. This is from your current book, directly from Kearns. It's just showing you the relationship between CD4 and the development of opportunistic infections. So you can see the different types of manifestations you may have at various levels of the CD4 count. Remember, our normal is 500 to 1500. So for those patients, when there's drops below 300, they may experience more vaginal candidiasis, oral hairy leukoplakia, Kaposi's sarcoma, and it goes under 200. Then we might see that pneumocystic pneumonia, that cryptococcosis, CD4 under 50, histoplasmosis, DMV retinitis, is we're going to talk about. So you can see the different categories for the CD4 count there. This is just a resource that's World Health Organization staging, and they use it based off symptoms, what the symptoms patients have. So this is just for reference. That video is for reference. It does play, but we're not going to play it. The United States Preventative Task Force recommends clinicians screen all pregnant persons. All pregnant persons must be screened for HIV, whether they present in labor or after the delivery. HIV status, if it is not known, you have to test them. For you as clinicians, any adolescent or adult between age 15 to 65 needs one test at least once in their lifetime. Adolescents and adults, 15 to 65, I think the CDC says 13 to 65, 13 to 64. But every person needs an HIV test at least once in their lifetime. And then, of course, if you have concerns. All right, so this is the testing. This is a busy screen, but we're going to break it down. So HIV tests are typically very accurate, but no test can detect the virus immediately after infection. The first 10 days, remember we said the virus is hidden. It's hiding itself, you can't find it, but it's still making copies during those first 10 days. How soon a test can detect HIV depends on the type of test. So we have 4 tests here that we're going to talk about. 3 tests for HIV are the first 3, and then there's a screening, the rapid HIV, which we'll talk about in a second. So the initial test that you should be using is called a 4th generation HIV antigen antibody immunoassay, also called an ELISA, which stands for enzyme linked immunosorbent assay. So the first test is a 4th generation HIV antigen antibody immunoassay. This is looking for antibodies to HIV-1 and HIV-2, and also an antigen called P24. So when you're first infected with HIV, before your body has a chance to make antibodies, there's a high level of P24 antigen in your blood. So that test will look for those components. It is detectable in 99% within the first 6 weeks after infection. We're going to start with the 4th generation, or the ELISA. If that test is reactive, reactive specimens are then tested again for confirmation or for typing. So that first test is completed. If it's reactive, then you need to order an HIV-1, HIV-2 differentiation immunoassay. Some literature might say you need to confirm with a Western blot. That's old. That's from when I was in PA school. They don't use that test anymore. They are now using HIV-1, HIV-2 differentiation immunoassay. They are not using Western blot anymore. So basically, that test is going to confirm and distinguish the type. The HIV-1 or is it HIV-2? And what do we say we're probably going to see most? 1, yes. If positive, and your 4th generation shows reactive antigens or antibody, is nearly 100%. So if you do your 4th generation, it's reactive, you test with the differentiation, it's positive, almost 100% positive for HIV. If you do the differentiation and it's negative, but you have the reactive on the first, then you need to do viral loading test, which is next. The HIV-1 RNA nucleic acid or NACS testing. The NACS testing will measure the amount of actively replicating HIV in the virus or the viral load. It's an accurate indicator of viral activity and helps us determine response to treatment as well. If it is detectable, more than likely that patient has HIV. If it is detectable. So you did the first test, 4th generation, reactive. Came down to the differentiation, negative. When you did your NAT test, there's a virus there, HIV. If it's not detectable, you did your test, your differentiation test is negative, and they're not finding it, it's possibly a false positive from those other tests. And you can have false positives from recent flu and hep vaccinations. Autoimmune diseases can also show false positive, as well as patients who've had multiple pregnancies. Lyme's disease, lupus, syphilis all can show false positives sometimes if you've recently had any of those vaccinations or you are diagnosed with any of those things. The higher the viral load with that test, the poorer the prognosis for most patients. We also said that it can be used as a response to treatment. So let's say you started your patient on antiretrovirals, you did NAT testing before you started, you did NAT testing after. If that viral load is going down, that tells you your treatment is working. If your viral load isn't changing or it's going up, you might have a resistant, you might be resistant to the medication, and you might need to change it. So then we have the rapid HIV antibody test. That is a screen. That is something patients can do at home. That is something you might be able to offer in your office. Usually the results are available within 10 to 20 minutes, but that test must be confirmed. So if you did an HIV antibody screening test in the office, you still need to send those patients to the lab for the other test. A lot of patients like to do it at home. It's a very sensitive matter. They may not be ready to face the music and see a provider for it, so they may want to do test at home first. Another test we use for HIV is the CD4 lymphocyte count, when we just talked about that. If that count is under 200, it's more likely AIDS. So we use it to determine the stage of the infection as well. Questions about testing? Yes.
What was the rapid test? You said that transmission is not super likely from saliva, but we can use rapid tests with mouth swabs.
So you do, but it's not just like a spit. You have to actually get in there and rub the cheek. You have to get that saliva, and it's basically DNA from the inside of the mouth. Like when they do paternity tests, that hard swab is the same. And they will say that inside of the instructions for the patient, it says that they have to get a swab from the cheek. This is our turnaround time for testing. That's why we said in stage 1, that acute phase, that you should get NAT testing, because that's the earliest one. You can get those results. It'll show infection in 10 to 33 days after the exposure. I misspoke. I said turnaround time. This is not the turnaround time slot. There's another one for turnaround time in when you order the test and get your results. This is not it. This is for post-exposure. So once you've been exposed, when can that test pick up the virus? The first is the 4th generation. It will not show any infection until 18 to 45 days after the infection. Next, like I said, it's the earliest to detect at 10:33, and then rapid HIV antibody test 23 to 90 days after exposure. So for the other stages, you can use any of these, but if it's the acute phase and you're concerned, that NAT testing is going to be the earliest to detect.
Going back a slide for a second,
Yes.
with the NAT testing, since it is detecting your viral load, and if you had the positive, like HIV-1/2 differentiation immunoassay, would you also just order the NAT testing to see what their viral load is, or do you just go to the CD4?
You could.
Okay.
Yeah, you could, absolutely. Because you're probably going to treat them anyway. If it's showing something, so you're going to want to get that. All right, again, a resource, HIV testing. You do have to report HIV. But in terms of testing, there are a lot of rules by states. It's state mandated how to get consent to test. For the state of Maryland, A patient's general consent for medical care and procedures is adequate for conducting HIV tests, and that includes any other test you want to get after that. You do not need a separate form to get HIV testing. And that's just for you to know, just as a clinician. This is information you're not going to be tested on, but you do not need any separate tests for permission. Once you get permission from the beginning to run some tests, then you're good to go. All right, so let's look at a case. Patient is a 38-year-old cisgender male who underwent HIV screening as a part of a blood donation. He was told the test result was positive for HIV-1. You have the lab results, which show the HIV-1, HIV-2 antigen antibody was reactive. The HIV-1, HIV-2 antibody differentiation was negative. What is our next test? NAC testing, right? So we're going to check that viral load. What if the HIV-1 antibody differentiation was positive instead of negative? Do they have HIV? Yes. More than likely they do, absolutely. All right, so there was a survey in 2020 of US primary care providers. Of those physicians that they surveyed, only 1% reported providing care to HIV patients. 1%. So most of these patients probably won't be seeing you. You might test them initially, but more than likely they're going to see internal medicine specialists who have a subspecialty in infectious disease or infectious disease. Surprisingly, of that survey, they said that they would be comfortable managing HIV, but if they had some additional training. So on Tuesday, we talked about prophylaxis, treatments, and being on antifungals for months and months and years. More than likely, you're not going to have to manage that. There has to be someone who is very knowledgeable in terms of the treatment, given all those side effects and things like that. So more than likely, you're So let's take a look at the possible workup in a patient who is HIV positive by testing or history that presents to your clinic as a new patient. So the goal of this initial evaluation is, one, confirm the diagnosis. If they tell you I have HIV, then you want to confirm that. If you're testing them and you find that they're HIV positive, of course, that's your documentation. You want to obtain a baseline history, and then you want to get some labs. Also, as part of this initial workup, you need to make sure your patient understands the disease, understands the course, understands how it's transmitted, and then try to start initiating care. So there are several tests. We have the antigen antibody testing, things like the CD4 cells, viral loads, CBC, CMP, bilirubin, serologies for hepatitis. You might check for anemias. You're going to do some glucose testing, serum lipids, pregnancy test in every patient with a uterus. Pregnancy test in every patient with a uterus. So if the patient comes in and they are HIV positive, then do the pregnancy test. Genotypic drug resistance testing. So this testing is usually recommended at the beginning of care to help you decide which antiretroviral you want to use. There are some patients who are resistant to certain types of treatment. And that is for basically the naive patient, person that has never had any retrovirals. You do not want to delay starting treatment, waiting on your test results for your labs. This can be modified in terms of the genetic drug resistance testing. You don't want to wait to start treatment for those to come back. Just go ahead and start If something comes back as resistant, then you can change the regimen. HIV treatment goals. We're gonna start treatment as soon as possible, especially for all people living with HIV at the time of diagnosis. Anyone who has a CD4 cell count less than 500 cells per microliter, anyone with a high viral load, anyone with AIDS-defining illness. The goal is to completely suppress viral replication. So maximally suppress the plasma HIV RNA. We want to restore their immunologic function, try to build their immune system back up. And by treating, we are hoping to reduce HIV-associated morbidity and prolonged duration and quality of survival. Lastly, we want to prevent HIV transmission. This is what it is going to take to end this epidemic. Gotta know how it's transmitted and practice safe sex. Patients who are having trouble with drugs, possible drug rehab, things like that. And there's also PrEP, which is pre-exposure prophylaxis. So you can do that if you're an at-risk person. All of the drugs that we use in some way interrupt that cycle. So we talked about 7 steps. And all of those drugs at some point interrupt that cycle. HAART or ART, HAART stands for highly active antiretroviral therapy. Highly active antiretroviral therapy. Most literature just calls it ART, antiretroviral therapy. So we're going to take a look at combinations. Hopefully today, Dr. Noel is going to go over this with you. There are several drugs in these classes of medications. There's like 25 different medications in 6 different classes. So hopefully he'll go over those in detail so you can get a better understanding. But in general, for a patient that's never had treatment, this is the combination that you're going to start with. So I put down at the bottom what these stand for. You can know the definition. And you see the first 2 are reverse transcriptase inhibitors. So we talked about that step, reverse transcriptase. That's the enzyme that comes in and changes that RNA to DNA. So if you can stop that if you can stop that process, you can hopefully keep some of that replication from going down. Then you'll see INSTI, which is for integrase inhibitor. Then there's the protease inhibitors. So all of these, remember those steps, the integrase comes in and helps it integrate into the nucleus. The protease comes in at the end and makes it mature and infectious. So we're trying to break the cycle at some point, that's how those drugs work. And then the last one is DTG and 3TC, which is a different combination. We're not going to talk about that. But typically you would use 2 NRTIs and 1 NNRTI, or 2 NRTIs and 1 integrase inhibitor, or use the 2 NRTIs and a boosted protease inhibitor. So you can see for most of those combinations, you're always going to start with the nucleoside reverse transcriptase inhibitor, the NRTI. 2 of those, and then 1 of the others from one of the different groups. So, like I said, hopefully you'll get some more detail on that, but you'll see on the list several different things, which is while a lot of PCPs do not want to get into this, a lot of different combinations, a lot of different drugs. Of course, they have side effects. You'll see the Barbie, the Dovato, Descovy, Truvada, which those have commercials, so you probably hear those on TV. Very common to see those commercials. I think I put in your resource, it might help you recognize these. The integrase inhibitors have Tegra in the middle. So integrase, Tegra, that's part of integrase. So that might help you remember those. And all of the protease inhibitors, the protease inhibitors in the beer. So that might help you to study or recognize them. Integrates has integrated, basically as part of integrating it. And then the beers for all of those. Despite major improvements in effectiveness and tolerability of antiretroviral therapy, only 60% of people living in the United States with HIV are virally suppressed, where their viral load is not detectable. So we still have work to do. This is basically how you're gonna monitor the treatment. Checking that viral load at the initiation of treatment and then 4 to 8 weeks after your treatment. Again, you probably won't be doing a whole lot of this, but if you are, this is a reference. Every 3 to 4 months, once stable. CD4 count, you're also gonna check at initiation of treatment, and then 3 months after that. Every 3 to 6 months, the first 2 years. Adherence. It's important that they adhere to their medication. It leads to increased symptoms, disease progression, and drug resistance. Education, 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 education. The only way we're gonna end it, HIV prevention, transmission. They need to inform all of their sexual partners. If that person is HIV positive, they need to let all their sexual partners know. Sometimes the patient is able to give that information and the health department will call. But their sexual partners need to know. Clean needles, if they're injecting drugs. There are people that are on the streets trying to help drug addicts with needles and not sharing, using clean needles. No circumcision reduces the likelihood of HIV infection. Of course, clean condoms. HIV positive female must be treated during pregnancy to prevent that transmission to the child during childbirth, prevention of breast milk, and then PrEP. Says the use of Truvada, brand name, reduces the risk of sexually transmitted HIV infection. So these patients who may practice at risk practices, or they're just at a higher risk, they have a lot of sex partners, don't regularly use condoms, things like that, whatever it is. Truvada might be something helpful because it prevents it reduces the risk of transmitting it sexually. PrEP, we talked about just now, Truvada is one of those. 99% effective in preventing the transmission through sexual contact. They say for drug users, it's about 74%. Takes about 7 to 21 days to take effect. $26 to $500 for a month's supply. It just depends. Generic coverage is now being required by federal law. Descovy is another version. That one's $2,000 a month. So not very, don't know if too many people are jumping on that one, unless your insurance covers it. Post-exposure, which you should be aware of as clinicians, if you get a needle stick, what should you do? So there's some risk on the side in that picture. If you are splashed with bodily fluids, there's near zero chance of getting HIV exposure, even if the fluids have blood in them. If the fluid splashes intact skin or mucous membranes, it's extremely low, even if blood is involved, and needle stick is still less than 1%. So still be careful, wear your gloves, take your precautions. If you do get a needle stick, which unfortunately I have had a needle stick, you must be started, the treatment must be started within 72 hours. Workers' comp usually gets involved and they kind of go through how to get tested for what treatment you need if you need it. Unfortunately, I didn't have to do any of the post-exposure for HIV, but so this is the way that you would look at that, depending on the status or the source. You don't know, source isn't available, don't have to consent, have them to consent or refuse HIV testing, then you need to be treated, and that would be the form of treatment you don't need to. Just remember, it must be started within 72 hours from the exposure. 72 hours from the exposure, there should be some type of prophylaxis or treatment. Or at least just a visit with workers to see what you need to have done. Resource on PrEP and PEP. And watch those on in your readers. There is non-occupation post-exposure prophylaxis used in sexual exposure, and I'm not so sure if Ed talked to you all about that when you had your course last fall. But these are just to, be aware of. Clinicians should provide treatment for gonococcal, chlamydial, and trichomonoid infection. All right, we're gonna do a couple more slides and then we're going to take a break. So, when I was younger, my mom's hairstylist died from HIV. I was too young to really understand it at that point, but when I was in high school, I saw this little girl on Oprah. Infection, the virus usually latent, but can reactivate. So this is typically asymptomatic, handled by our immune system, don't even know that we've been infected. It is part of the herpes family, human herpes virus 5. It presents with, let me go back, transmitted by direct contact with bodily fluids, urine, saliva, blood, tears, semen, and breast milk. Can also be transmitted through sexual contact or childbirth. It presents with a mononucleosis-like syndrome in the immunocompetent. We haven't talked about EBV yet, but what symptoms do we remember about mono?
Splenomegaly.
Exudate, yeah, exudative pharyngitis, swollen tonsils, lymph nodes, swollen tonsils, that type of thing. So this is like EBV without the pharyngitis and without the lymph nodes. So patients will present with fever, malaise, myalgia, arthralgias, splenomegaly. So that's very much so like EBV, abnormal liver enzymes. They have negative heterophil antibodies. So this is your comparison. See a patient with these symptoms: fever, malaise, body aches, enlarged spleen. Then it might help you determine between CMV and EBV or mono if they have heterophil antibodies or not. With this CMV, they usually do not have any heterophil antibodies. It causes CMV retinitis in the immunocompromised. CMV retinitis in the immunocompromised. It is a serious disease in patients who have a weakened immune system. CMV retinitis is an inflammation of the retina that can lead to blindness. And if you remember from your chart, which you probably don't because there were 1,000 things on there, this is patients with a CD4 count less than 50 microliters. So CMV retinitis occurs usually in our HIV patients whose CD counts are below 50. Typically, asymptomatic, you don't really worry about it, but it can reactivate. So 70% of the people in the United States have it, but then you're infected with HIV later on down the road. This can reactivate. Typically, we'll call it CMV retinitis in those patients. The CD4 count is below 50. It could possibly cause CMV colitis, so that's in patients with CD4 count less than 100. If your patient has HIV and they come in with worsening vision, should be on your radar. HIV patient with worsening vision. Any type of visual disturbances should be something you're thinking about.
Got it.
Our high-risk groups, a major source of CMV for pregnant women are their own children, typically in daycare. This is a great little slide because it kind of gives you everything real quick. But typically, high-risk groups are pregnant women. Infants are also at high risk, and immunocompromised people. For this lecture, for Clin Med, this is not peds. We're thinking of the adult pregnant women, and we're thinking of immunocompromised patients. So for pregnant women who have young children or who work with children, they are at a high risk of catching CMV. 75% of toddlers have CMV in their urine or saliva in studies at child care settings, 75%. So definitely want to wash your hands, wash your contact with bodily fluids with kids under the age of 6 if you're pregnant. Also, don't want to share utensils, drinks, or toothbrushes with kids under the age of 6 if you're pregnant. Avoid contact with saliva, kids under the age of 6 on the forehead or on the forehead instead of lips or cheek. In pregnant women. So remember, pregnant women and immunocompromised. Pregnant women, immunocompromised, CMV retinitis and immunocompromised. Can also be post-transplant patients. Congenital CMV is the most common congenital infection in high-income countries, but you will learn more about that in your PEDS section. CMV diagnosis and treatment. Diagnosis can be made by detection of the CMV DNA. Cultures are of little use. Typically, there are ophthalmoscopic findings. Pizza pie retinopathy, if that looks like a slice of pizza to you, that's what they sometimes describe it as. It's a neovascular proliferative lesion on the exam. Some people say scrambled eggs with ketchup. So whichever one helps you memorize it, CMV, pizza pie, CMV, scrambled eggs and ketchup. Whatever you need to remember it, but that's what you're gonna find on your eye exam. If you're healthy, remember it's asymptomatic for most, self-limited, don't really need to do anything. But if you're not, and you have symptoms, you need to treat with antivirals. Ganciclovir, first-line treatment. Ganciclovir, first-line treatment in CMV. Ganciclovir. Prevention education is important in pregnant women, making sure they practice good hand hygiene, especially after changing diapers, wiping their noses, avoiding kisses, and not sharing the fork or spoon with their babies. Prognosis and complications, CMV retinitis, CMV retinitis, CMV retinitis in HIV patients. This is an AIDS-defining illness. This is a sign that your HIV is progressing. Your HIV is not being treated well. Indicates a poor prognosis. Moving on. Epstein-Barr, EBV, we just talked about. Main cause of infectious mono. EBV can also cause some other things. EBV-related diseases, Hodgkin's lymphoma, non-Hodgkin lymphoma, Burkitt's lymphoma, nasopharyngeal carcinoma. Epstein-Barr virus, or EBV, is another human herpes virus, human herpes virus 4. It is a double-stranded DNA virus that infects oral pharyngeal epithelial cells and B lymphocytes. Infects oral pharyngeal epithelial cells and B lymphocytes. So that can kind of tell you where it's gonna kind of settle. Epstein-Barr virus, or human herpes 4, is one of the most ubiquitous human viruses, infecting 95% of the population worldwide. 95% of the population worldwide are seropositive for EBV. That virus usually persists for the lifetime in the host. So if you had it once, you test for it, it's going to show up. It can occur at any age. Infected during childhood, if infected during childhood, usually they do not cause symptoms. I disagree. I was diagnosed with EBV when I was 8 years old. And my mom teased me, she said, "You have a kissing disease." I said, "I have a great." I didn't know what was going on, but I definitely had symptoms. So, you know, everything is not 100%. When symptoms develop, it's usually seen in teenagers or adults. Again, it's the most common cause of infectious mononucleosis. EBV, the most common cause of infectious mononucleosis, especially college students, 15 to 30. Patient home from spring break, came in with enlarged tonsils, exudated, da 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 da. This is what you should be thinking about. It becomes inactive after infection, but can reactivate and cause symptoms in the immunocompromised. It can cause oral hairy leukoplakia and Burkitt lymphoma in HIV. Burkitt's lymphoma is a rare type of non-Hodgkin's. I don't know if y'all talked about that with Dr. Phil or Dr. Professor Miller. Very rare. But if you see those in an HIV patient, could be from EBV. How are these patients going to present? So infectious mononucleosis or mono, the kissing disease, also called glandular fever, is transmitted by saliva. Transmitted by saliva. You can also recover it from genital secretions, and it is also a possibility of being transmitted through blood transfusion or organ transplant. Typical symptoms of infectious mononucleosis usually appear about 4 to 6 weeks after the infection. 4 to 6 weeks, the incubation period. And there's a symptom triad. We're going to talk about several of the symptoms, but the triad you should be thinking about. 16-year-old patient presents with fever, pharyngitis, and lymphadenopathy, particularly posterior cervical lymphadenopathy. Back here, under the ear. That is your symptom triad that should make you think about EBV. So we talked at the beginning when we were looking at the viral or the virus itself, and we said that it lands in epithelial cells, oral pharyngeal epithelial cells, and B cells. So those are going to land in your throat, and the B cells are going to travel to your lymph nodes. So that's how that works. That all comes together. The posterior cervical lymph nodes drain the tonsils, so we would expect those to be enlarged. Symptoms usually resolve in about a month in most patients, but you can still feel tired and sleep more than usual for as long as 6 months. Major cause of fatigue. So we're going to take a look at a little bit more detail of the symptoms of the prolonged fatigue or malaise. Like we just said, it can last for months, up to 6 months, even after. There's a tonsillar pharyngitis. Could be exudative or non-exudative. Possible uvular edema, so the uvula could also be swollen. Fever usually resolves over about 3 months. They can also have myalgias or arthritis, nausea, no appetite. You see the picture of the mono there, classic. Additionally, that lymphadenopathy usually enlarged, discrete, non-suppurative, minimal or slight pain. Again, posterior cervical lymphadenopathy and posterior cervical. Transient bilateral upper lid edema, which is the top picture, little puffy eye, that's called a Hoagland sign. Splenomegaly, very common. Up to 50% of patients can have splenomegaly, and that spleen can be massive. Patients may have conjunctival hemorrhage, you see on the picture. A maculopapular rash, sometimes a petechial rash. Use of amoxicillin raises the risk of the rash. So remember, EBV is caused by what? What is our topic for today? Virus. A patient goes in, oh, that looks like strep pharyngitis. Here's some amoxicillin. See you back in a week or two. Patients who are treated with antibiotics have a higher incidence of the rash. The mechanism for that rash is not well understood why, but that is the pattern. Patients treated with ampicillin or amoxicillin are more likely to develop a rash. And this is common in younger individuals. That bottom picture, you can see that soft palate petechiae. That might be noted on your exam as well. Complications. In people with mono, sometimes the spleen grows so large that it tears. That's a splenic rupture. This is rare, but can be life-threatening. Can occur even after mild abdominal trauma. Your job as a clinician, treated a patient for mono. Patients who especially are in sports need to avoid contact sports for at least 4 weeks. Rest and restriction from weightlifting and contact sports should be implemented at least for the first 4 weeks of onset of symptoms. That is what you need to remember. Restriction, restriction, restriction. Some people will even do abdominal ultrasound to clear the patient, especially if they play sports. So you'll want to ask your patient, are you, what type of, that's where your history comes in. What do you do for exercise? Well, I go to the gym, I lift weights 4 times a week. They need restrictions if you treat them for mono. Those patients also need restrictions. So I don't do anything, I just lay around on my couch all day. They probably are. But anybody who's doing any type of weightlifting or plays contact sports, remember this is more common in 15 to 30. So there's a high chance that they may play sports or have some type of gym routine, that age group, high school, their NPE, whatever it is. Remember restrictions, at least 4 weeks. Your differential, several things, strep, CMV, acute HIV, they've got lymph nodes, secondary syphilis, they've got a rash, rubella, we're gonna talk about that, drug hypersensitivity reactions, it could be several things. It is a common cause of false positive syphilis testing. EBV is a common cause of false positive syphilis testing, so that's in there as your different. How do we make the diagnosis? Characteristic findings. Tonsils, lymph nodes, seeing all those things, patient is tired, oh, I just don't know, I just don't have enough energy, I don't even feel like going to do anything, I'm just, not feeling like I have the energy. Characteristic findings of EBV. Serological evidence of the infection, you can do a monospot or heterophil HA antibody test. Antibodies are often present. Heterophil antibodies are often present. Remember, we were trying to differentiate between CMV because CMV is monolite. If they have the positive antibody, it's probably EBV. If they don't have the heterophil antibody, it's probably CMV. There are other tests as well that can detect past or present infection, IgM, EBV. I don't know how much you would be doing that in the clinic. We used to order them quite a bit in ENT though for patients with chronic issues, especially if they came in after us because they've been treated by PCP multiple times and now they're coming to us later on. Our quick tests aren't going to be positive, so we can check for past infections with the immunoglobulin. And you can look, I don't know if it's in the resource, it may or may not be, but if it is, if I added it, there's a chart that you can look at to say, oh, if this is positive, the virus is likely present now. If this is negative, but this is positive, you probably had a past infection. But that you don't need to know. Just know you're going to order heterophil HA antibody test or monospot, and you're going to diagnose by characteristics. Treatment. No specific treatment needed in 95% of patients. Remember, this is a virus. NSAIDs or acetaminophen if needed. Warm saline throat irrigations or gargles 3 to 4 times daily. If the throat culture grows beta hemolytic streptococci, you want to treat 10-day course. But remember, that incident of rash is gonna go up. If you use amoxicillin specifically or ampicillin. You have some other options there. Corticosteroids reserved for complicated cases. And you can see some of those cases down there that you might use that impending airway obstruction. I have used corticosteroids for mono in the past when the tonsils were 4+ touching each other and I couldn't see any of the airway. The patient just was significantly in discomfort. Studies have shown acyclovir decreases viral shedding, but it shows no clinical benefit, so that's not on the treatment. All right, we're gonna do a little bit of PEDS ID and vaccine preventable infections. This little guy looks so stressed out. So we're going to talk about some of those things, but again, Clin Med is supposed to be for adult medicine. So a lot of these, you'll go into more detail with Professor Rogers. You've probably already seen some in the fall. You'll see him again when she does Infectious in the next week or two. A lot of these infections are vaccine preventable. That's very important for you to remember with these. What is vaccine preventable and what is not? So we'll do first a question. A 3-year-old boy is brought to the office by his parents due to a facial rash. The parents report the patient has been having a runny nose, diarrhea, and a fever of up to 38.3 degrees Celsius or 100.9 degrees Fahrenheit for the past 3 days. Today, the patient developed a rash on his face, shown below. Laboratory evaluation is significant for a hemoglobin of 9 grams per deciliter and a leukocyte count of 3,000 cells. Which of the following best describes this patient's characteristics of the positive organism? A non-enveloped double-stranded papillomavirus. B, a non-enveloped single-stranded, I don't know if that's supposed to be herpesvirus. C, non-enveloped single-stranded parvovirus. D, non-enveloped double-stranded reovirus. Or E, enveloped double-stranded poxvirus. Is C the general answer?
Yes.
Very good. Parvovirus B19, or slapped cheek syndrome, Fifth disease. So just do a brief summary of this. These are directly from Professor Rogers' lecture. But you know me, I like the bold things for you.
Thank you.
So this is slapped cheek or Fifth disease, parvovirus B19, usually asymptomatic, mild febrile illness with a rash, transmitted by respiratory droplets. Can be transmitted through vertical transmission. Childbirth, blood product, usually affects 5 to 15-year-olds. Incubation, 4 to 14 days from the exposure.
Same shit.
Diagnosis is usually clinical. We're going to see resolution in about 2 to 3 weeks. Treatment can be supportive or just treat symptomatically, incest or arthralgias. Or you could give intravenous immunoglobulin therapy if the patient has anemia. Clinical findings, most contagious prior to the rash. Most contagious prior to the rash. These patients have a fiery red slack cheek appearance with that circummoral pallor, so it does not extend around the mouth. The bottom picture shows that lacy maculopapular rash, typically on the trunk, limbs, and buttocks, spares the palms and the toes. If you're studying these, I would do rashes that speck the palms and the soles, ones that spare the palms and the soles, and try to remember, figure out a way to remember which is which, because that's gonna be a lot of your when you're looking at stems, how you're gonna differentiate between some of those. Patients may also have mild fever, malaise, headache, itchy skin. It can occur in middle-aged people, especially women. They may present with just painful joints and no other symptoms. It's usually symmetrical, hands, feet, knees. For your differential for that, it mimics lupus or rheumatoid. So it can affect middle-aged women as well, but typically for the case, this class or your peds, we're looking at 5 to 15. We're looking at kids. These are not super common. Immunocompromised patients also at risk. You see who those patients are. The virus in people with anemia may stop the production of red blood cells and cause an anemia crisis, transient aplastic crisis. So you want to be mindful of that. Patients with sickle cell, G6PD deficiency, acute leukemia, CML, and HIV. In pregnancy, bold it down there. This can cause fetal loss, hydrops fetalis, that increased buildup of water. Fifth disease. Maternal infections usually occur in the first half of pregnancy. Some of our vaccine preventables. HPV, did you all go over HPV? You should have, yeah. So I'm not gonna really go over this one too much. The next slide, I really, really like because it kind of gives you everything in one. Not my section, the chart, and I put stars by what I think you should remember. The test questions are gonna be about, human papilloma in the form of the cutaneous warts. Cutaneous warts are caused by types 1 and 4, those are usually benign. Oftentimes asymptomatic, but when they do show up, you might have warts on your fingers and hands. There's common type plantar on the soles of the feet, black on the arms, face, and knees. Performance. The blue box, the genital tract, you know that type 6 and 11 cause warts, condylomata acuminata, those are rarely cancerous. 16 to 18, more common with neoplasia. 16 and 18 associated with up to 70% of all cervical cancers. Those that I definitely want you to remember. But I think this is a good overview of the diagnosis, the treatment, which could be medical or surgical, depending on the ward, because it might be. So yeah, that is a good overview. The conditions range from not having any symptoms at all to cancer. So definitely just be mindful of that and review your past notes. Recommended treatments. This is a resource for genital warts and the different treatments. Flu, influenza, we'll talk about next. Caused by orthomyxovirus. Typically transmitted by respiratory droplets. 3 antigenic types infect humans, types A, B, and C. And they get this category, this typing by the surface, if they have hemagglutinin or neuraminidase. Type A and B produce identical clinical symptoms. A and B cause those seasonal epidemics that we see in the winter or flu season. We're talking about flu season, it's usually type A and B. Type C usually produces a milder disease. Of type A and type B, type A is typically more pathogenic. Who is at risk? A lot of people are at risk, especially pregnant women, children, and the elderly. Flu is so common. There are billions of cases every year. Most people don't need any type of treatment. But I definitely want you to be mindful about pregnant women, children, and elderly. Underlying medical conditions, patients on immunosuppressive therapy, or the immunocompromised. These patients are at risk for severe disease. Healthcare workers also at risk. So we are at risk. A lot of places will try to mandate, they'll try, you don't necessarily have to do it, but they'll try to mandate shots. We're around so many patients and we don't want to get sick ourselves, nor do we want to keep spreading it to vulnerable patients. So vaccination is recommended to protect health workers. Incubation is around 1 to 4 days. Typically an abrupt onset of fever, chills, dry cough can last up to 2 weeks. Headache, myalgias, malaise, sore throat, runny nose, or rhinorrhea, congestion, GI symptoms. Children often develop diarrhea. Those are the GI symptoms there. Elderly patients might not have a might not have a fever, and nor they may not have any type of respiratory symptoms. Sometimes elderly patients with the flu are just confused and tired. Elderly patients may just present confused and tired. On exam, these patients may present with a flushed face, redness in their face, redness in their throat. And they might have some lymphadenopathy as well, cervical lymphadenopathy. Differential grand. This is just for comparison's sake. A lot of different things can seem like the flu or regular colds, but then there are other viruses, several other viruses that might have a similar presentation. If it's flu season, are you gonna go through a bunch of different tests? Probably not unless the patient's just not doing well. How do we test? Rapid influenza diagnostic test, widely available to detect the antigens from nasal and throat swabs. Usually can get your results in 15 to 20 minutes. It is highly specific. Low sensitivity can lead to high false negative results. Some tests, but not all, might be able to differentiate between the types, but some may just have a positive and not give you a type. There are different subtypes on A, and that just talks about none available that can provide information on the subtypes. Just know type A, B, take A and B. Type A and B, you don't need to worry about subtypes right now. Treatment, supportive care, rest. Might need cough drop, they have cough for up to 2 weeks, and they might need cough suppressants. They may need pain relievers. They have muscle aches, headaches, they might need something for that. Medications, you should talk about this afternoon. But typically the treatment of choice is oseltamivir or Tamiflu. Treatment of choice, Tamiflu, oseltamivir. 75 milligrams twice daily for 5 days. This is the medication of choice for patients of any age, pregnant women, and patients hospitalized or have complicated infection. There are also some other varieties that are available, inhaled, IV, and another oral. So Fluzia, you can use that for post-exposure prophylaxis. My mom has flu, now I need to go get the flu treatment because we live in the same house, that type of thing. But remember for this, oseltamivir or Tamiflu is your treatment of choice. And you need to treat within the first 48 hours of symptom onset. Treat within the first 48 hours. So your question may say it's been 3 days since, or let's just say 4, I'm sure they won't put it that close, but some data that show you can treat within 72 hours. But they say 5 days ago, patient presented with blah, 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 blah. Your treatment options include da, 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 da. It might say supportive care, it might say Tamiflu, it might penicillin and amoxicillin. If it's been 5 days, you're not gonna treat that. Not gonna work. You need to treat within the first 48 hours of symptoms, or they're just gonna have to let the virus run its course. These are old school masks. You've seen that they've changed since. Even though some people still wear them, their masks like that with their mouth still out. That's how they used to wear them back in the day. They look like, his looks like leather or something. We are going to prevent flu by encouraging flu vaccinations. Best way to prevent influenza is to get a flu vaccination every year. Constantly changing. Scientists work to try to identify the strains that they think will cause the most illness and create new vaccines based on those recommendations. Wash your hands, cover your sneezes, general things to help with not transmitting that, because it is through respiratory droplets. Vaccines are available. There are there's 4 different types, injectable vaccines that protect against 4 different strains. There are 2 for type A and 2 for type B. There are also nasal sprays that have the live attenuated virus that cannot cause illness. And it's generally safe in egg allergy. So that may be a question that you see. Patient has an egg allergy, should you treat? Typically, it's safe in patients with egg allergies unless they've had a severe reaction. They will need to get their vaccine in the office and be observed. But they can still get it most cases. Recommendations: who can get the flu shot, who should not get the flu shot. There are standard dose inactivated flu vaccines approved for people as young as 6 months. You will not give the flu vaccine in someone younger than 6 months. That's on the other side, who should not get the vaccine. Some are only approved for adults. Pregnant women need it. Remember, pregnant elderly children. People with egg allergy, if it's just hives, they should be able to get it as well. People with chronic health conditions, so elderly, children, pregnant women, underlying medical conditions, immunosuppressed. Those are the ones we talked about. People who shouldn't get it, if you've had a severe or life-threatening allergy to an ingredient, like a gelatin, or if you've had severe life-threatening allergies to any type of antibiotics, they may not be the best candidates. People who have had a severe allergic reaction to the flu vaccine before, they may not be a good candidate. Some studies show that patients with a history of Guillain-Barré should not receive it, or you need to take special precautions. There are people who are not good candidates for the nasal form of the vaccine, and there are a ton of different reasons why, or who should get the nasal versus not, versus the IM. Right. We'll do a couple of these and we'll take a break. Historically, common childhood illnesses now are mostly vaccine preventable. Again, you are going to go over these with Professor Rogers, or already briefly went over them with her, or in your derm: measles, mumps, rubella, rubella, and varicella zoster, virus infection, chickenpox. This is straight from her lecture, her pictures, with a description of what we're seeing. For measles, there are the 3 C's: cough, coryza, and conjunctivitis. Cough, coryza, conjunctivitis. Measles: cough, conjunctivitis, coryza. Remember the 3 C's. Measles, also known as rubeola, is a highly contagious infectious disease of childhood, so that's not gonna be our main focus. It is a reportable, so if you have a patient with this, typically your lab is gonna turn it in once or you're gonna have to call, I think, patient has measles, blah, blah, blah. So you are going to need to report this. Several of these are reportable. Patients present with a prodrome, fever can be up to 105. They're fatigued or have malaise. They have the 3 C's, conjunctivitis, coryza, and cough. They may have lacrimation or photophobia with the conjunctivitis or teary-eyed, the eyes were super teary. Cold spots, that is pathognomonic, that is test worthy. Cold spots with measles, viola. These may appear on the palatal or buccal mucosa 2 to 3 days before the rash. Cold spots on the palate or buccal mucosa 2 to 3 days before the rash is pathognomonic. These patients have a brick red maculopapular rash that appears 3 to 4 days after the fever, after the fatigue, after the triple C. The rash comes after. It may appear when the fever spikes. So your stem might say something like, patient's mom brought in son who had fever for 2 days. Fever went up to 104 today, and then she noticed a rash. And then this rash usually starts around the face or hairline, the ears, forehead, somewhere at the top. And then it spreads cephalocaudally, so it goes down and out, so then towards the neck, the extremities, trunk. So starting up and then moving down. Affecting palms and soles last. Remember what we said, spares palms and soles, affects palms and soles. These are the things that you need to use to differentiate. It often coalesces and is gone within 6 to 7 days. The skin might slough off and look brownish after the fact. So we are looking at this in peds. You'll know it for them, for our, say, immunocompromised patients, if you're traveling to an area that it has a high level of measles, or exposure to patients who haven't been, or people that haven't been vaccinated, then you need to be on the lookout for those, and they need to be protected, so they'll need the vaccine if they have not already been vaccinated. Treatment and supportive prevention, vaccination to the MMR or MMRV. Mumps. I believe Professor Ryder says she has not done mumps, so we'll talk about this a little bit. It is also reportable, caused by the paramyxovirus, spread also by respiratory droplets or the respiratory route, and affects almost all non-protected children. Since the introduction of the mumps vaccine in the US, it is very uncommon to see here, so I doubt you'll ever see. But you could, depending on the situation, or maybe you're doing like the out of the country. As a result of prior clinical and subclinical infection or childhood immunization, 5% of adults are immune, although that immunity can wane in late adolescence. Infected patients are infectious from 2 days before or 5 days after the onset of keratitis. That swelling, which we'll look at in what you saw in the first picture. Incubation is long, 14 to 21 days. If you have mumps in an adult, it is usually pretty serious. Typically for me and ENT, if we see a patient, when we see a lot of swollen parotid glands, we'll always ask them, have you been vaccinated? It's highly unlikely mumps, but we always have to ask. After the prodrome of fever, severe headache, arthralgia, and anorexia, tender swelling of the parotid glands occurs, and this is in about 70 to 80% bilaterally. The ear is displaced upward and out, so the ear is going to come out because that jaw is starting to get big and push everything up. The mandibular angle is obliterated, so we go back. and look at this picture, you cannot see where his mandible and where that hand, you're not seeing that anymore, it's completely gone, wiped away. And you can even see his ear moving up. Probably wasn't like that, but that swelling is causing that ear to tilt up, so his ear is moved up, it's displaced, and he lost the angle of the mandible. Acidic foods usually stimulate the salivary glands to secrete more, so if they're secreting more, the saliva is going through that parotid, kind of hurts, so they usually don't like sour foods. Eating those can be quite painful. The orifice of the Simpson duct may be red and swollen. That Simpson duct is the one at the top, right under your teeth. You can feel it with your tongue. That's the opening there in the mouth. It could be red and swollen. You might see yellow secretion, but typically not pus. The swelling of the parotid usually dissipates after about a week. So far, it's caused by a paramyxovirus, spread by respiratory droplets. We know that it's not common here in the US, but for patients that do get it or have been exposed or not vaccinated, infectious, they're infectious from days 2 days before or 5 days after. The parotid glands are swollen, usually bilaterally. The ear is up and out. The mandible is no longer seen, the mandibular angle gone. And they may have redness from swelling of their Simpson duct. Complications, this is also possible test worthy. Patient presents with fever, and also notes, orchitis or testicular swelling. The testes are the most common extrasalivary disease site in adolescents and adults with mumps. The testes are the most common extrasalivary disease site in adolescents and adults. Typically unilateral. So high fever, one swollen testes that is tender, you should be thinking about mumps. It should be on your differential, it needs to be ruled out. This happens about 7 to 10 days after they already had the parotid swelling. So they had that first, it went away. Remember, it dissipates in about a week. But now, he's complaining that his testes are swollen, that the testes are swollen. Testes are swollen. This typically will resolve in 1 to 2 weeks. Although 1/3 of infected testes atrophy, bilateral involvement and sterility are rare. Treatment is supportive. Scrotal support might be needed for the orchitis. Remember that as your complication. Let's take a break until 10:30. And then we'll be finished up these. Here in the United States. If you see it, it's from a patient that has arrived here from infected from another country. Also called German measles. It is a toga virus that is typical. Symptoms, you might be in your STEM, you might see toga virus. So it's caused by toga virus, usually mild, self-limited. Transmission, also through in droplets or respiratory secretions. A fine pink maculopapular rash. The last one was a brick red maculopapular rash. So different ways to differentiate. The rash, typically they have also lymphadenopathy and a low-grade fever. The rash can start on the face, spares the palms and soles. So some that affect, some that spare. Remember that, and you're trying to differentiate. It is fainter than measles rash and does not collate. More prominent after a hot shower or bath. You might see the rash more after a hot shower or bath. You can have some polyarticular arthritis and arthralgia in adult women if they have it. Generally, no complications in children. Again, very rare, less than 10 cases a year in the United States. but you should be aware of it. Infection during pregnancy can lead to teratogenicity and miscarriage. Infection of a fetus following infection of the mother during pregnancy can have a devastating effect on the fetus. Infection of the fetus. Following infection of the mother during pregnancy. So if mom gets infected and the fetus gets infected, it can be devastating to that fetus and possibly cause miscarriage. The infection during the first trimester typically leads to congenital rubella in at least 80% of fetuses. These are more for the babies, sensory neural hearing loss and deafness. The primary complication in the second trimester. Other manifestations, that blueberry muffin rash, you might see. Diagnosis is clinical, or you can do serological testing for the IgM antibody. Going to treat supportive, and you're going to vaccinate. MMR, MMRV. So be familiar with that. Again, very uncommon for adults, so I'm going to skip on through. Roseola infantum. Roseola, benign, also a human herpes virus, either 6 or 7. 6 is a major cause of acute febrile illness in young children. This can be confused with more serious causes of high fever. For this, I would just remember that it can cause febrile seizures. Definitely can cause febrile seizures. The most prominent historical feature is an abrupt onset of a fever, often reaching greater than 39.5 degrees Celsius or 103.1. It lasts 3 to 7 days in an otherwise healthy appearing child. So the baby comes in, got this high fever, but he seems to be doing well. He's happy, he's his normal self. You should be thinking about roseola. HB 6 or 7. The fever will cease abruptly, and then that characteristic rash may appear. Rose pink macules or maculopapular rash on the trunk and neck, and then it spreads to the face, scalp, and extremities. It is not itchy, and it is blanchable and non-pruritic. Can occur in adults, but not common. Again, might see reactivation in our immunocompromised patients. Varicella and herpes zoster, varicella zoster virus or VZV. This is a DNA virus caused by human herpes group HHV3. Transmission, also respiratory droplets or contact with lesion, which is what I got from my classmate Corey in the 4th grade. He said, "Look on my arm." And I touched it, and the next day I had chickenpox. Yeah, it's pretty fun there. So I don't know if it was the next day, but definitely I got chickenpox like very soon after.
Good old Corey.
Corey, I'll never forget his name. Chickenpox, varicella, and shingles are caused by varicella zoster virus. The incidence and severity in herpes zoster increases with age. So if you're older than 60, you have a high incident, high rate. Anyone over 80, or by the time you're 80, it's a 10 out of 1,000 chance. Patients we're worried about immunocompromised and pregnant women. Symptoms and signs, fever and malaise. I put the 2 different types of rashes here because that is what you need for testing purposes and just for your knowledge, what they look like. The chickenpox is itchy, centrifugal, papular, it changes from vesicular to pustular, looks like 2 drops on a rose petal. That's very common to read or see. Finally, crusting. The zoster rash, a little bit different, tingling, pain, eruption of vesicles, and a dermatomal distribution. We're going to talk about that in a second. Evolving into pustules and then crusting. This is a clinical diagnosis. Should be noted where we have on the immunocompromised patient and immunocompromised and the pregnant for high risk, that does not include our HIV patients. Typically not common in HIV patients because most adults have had chickenpox or varicella at some point and they're seropositive. So it is uncommon. Virus is typically more severe in older patients. So we'll look at the reactivation with shingles. Latent VSV can reactivate as herpes zoster or shingles in about 30% of people. This can be precipitated by illness, stress, or advancing age. These skin lesions typically develop into clusters or vesicles over 3 to 5 days. They're painful and they are itchy or itchy. They'll usually dry out and press over. The pain comes before the rash. The pain comes before the rash. And it could be several days. The pain with zoster is severe. Severe pain. The pain comes before the rash and is severe. Usually follows a dermatomal distribution. Usually the thoracic and lumbar areas are most common. I remember seeing it when I was working at a clinic in Memphis. And I remember a patient had a big patch of it right there on his back. Very painful. Usually single unilateral dermatome is in most cases. It will never cross the midline. Cut your body in half. It's gonna be on one side, not gonna be on both. In disseminated cases, the lesions can cover 3 or more dermatomes, so it might be in 3 different spots. Usually for most, it's just a single dermatome, one area. Complications, postherpetic neuralgia, bacterial superinfections, superimposed infections, herpes zoster, ophthalmicus, Ramsay-Hunt. Hutchinson sign is when you have shingles on the tip of the nose. That can indicate possible corneal involvement or ocular involvement. That is something you should know. When shingles involve the first division of the trigeminal nerve, you might see something called Hutchinson signs, which are lesions on the nose. Herpes zoster ophthalmicus, not very common. You might see dendritic lesions on a There are vaccines available and effective against varicella and varicella zoster. Patients 50 and up should get the Shingrix zoster, should get the Shingrix vaccine regardless of history. When I was downloading this last night, I actually saw the Shingrix commercial on TV. It's like perfect timing. Treatments. If your patient comes in with this dermatome, crusting, severe pain, you want to treat with valciclovir or famciclovir. And you want to treat within 72 hours of lesion onset and continue that for a week until crusting of the lesions. Valciclovir or famciclovir, the treatment for herpes zoster. And again, we're going to prevent this by giving the Shingrix vaccine in anyone 50 and older, regardless if they already had a history of shingles. There's also another vaccine, an older live vaccine called Zostavax, which is sometimes more helpful in 60 and up, but Shingrix is the most common. That'll be your prevention. There are contraindications, life-threatening or severe allergic reactions with gelatin, neomycin, or immunocompromised may not be able to receive that vaccine. Let's do a little question before we move on to our next topic. A 16-year-old boy is brought to the emergency department for evaluation of testicular pain and scrotal swelling. He had an episode of bilateral facial swelling along the jawline several days ago with associated fevers, headaches, and myalgias. The pain is worsened with movement. He has no dysuria. He is not sexually active. Records demonstrate his parents refused vaccinations throughout childhood. Temperature is 38.2 or 100 degrees Fahrenheit. His pulse is 98, blood pressure 122/84. Physical exam reveals bilaterally enlarged and tender testicles. Stroking of the inner thigh bilaterally results in elevation of the testes. Which of the following is the most likely etiology of this patient's clinical condition? A, infection with an RNA paramyxovirus. B, an autoimmune inflammation. C, dissemination of gram-negative Neisseria. D, infection with double-stranded DNA virus. Or E, retrograde urethral ascent of E. coli. A, paramyxovirus, that is our mumps. Yeah, and so he had bilateral tenderness. Again, it's usually unilateral in 75% of patients, but it can happen that way as well. Your keys there, he had swelling in his jawline several days ago. He was not vaccinated as a child. And now he has bilateral tender testicles. More than likely, that bronchitis complication you should remember. All right, I'm gonna talk about polio. Polio is an old disease, believed to have been around since Egypt, ancient Egypt. President Roosevelt was diagnosed with polio when he was 39. So you may have heard of polio, but we rarely see it. Gonna look at a case. In June of 2022, a previously healthy young adult who was unvaccinated against polio presented to a Rockland County, New York Emergency Department with a 5-day history of fever, back and abdominal pain, neck stiffness, and constipation. Patient also noted a 2-day history of weakness in bilateral lower extremities. He was admitted with presumptive acute flaccid myelitis. Viral swabs were negative, nasopharyngeal and oropharyngeal swabs. Cerebrospinal fluid samples collected from the patient tested negative for enteroviruses as well as respiratory pathogens and encephalitis viruses. But on day 11 and 12, polio showed up in his stool culture. Poliomyelitis or polio. This was the second case of community transmission in the United States since 1949. Prior to his case, there had not been any polio cases in 40 years. How did he get it? He had been traveling, and apparently when they tested him, he had a vaccine-derived strain. So he was exposed to this certain strain of polio that was given in a vaccination. Vaccine derived. In other countries, they use a vaccine that is derived from the virus. We don't use that here anymore. But he was exposed to that. If he was vaccinated, he probably wouldn't have gotten polio. But that's neither here nor there. Since they were able to find that that strain was from a vaccine, then they assumed that he got it while traveling abroad. But that's pretty interesting. Transmission, typically polio is very contagious and it spreads through person-to-person contact. It can live in the infected person's throat and intestines. You can also get it from contaminated food and water. It is typically spread through fecal oral contact. There is some respiratory spread as well. Viral shedding, 1 week prior to symptoms and up to 2 weeks after. It is also associated with asymptomatic spread. There is only one type of polio virus that remains endemic. There's an indigenous wild polio virus type in Pakistan and Afghanistan. So if you had a patient that traveled recently to those areas or plans to travel to those areas, you're gonna need to be thinking about what you wanna do to try to prevent that. Or if a patient comes in and they've recently traveled and they got these symptoms, even though we have only seen 2 cases in 40 years, that should still be in your differential. Signs and symptoms, well, if they have symptoms, 95% are asymptomatic. When they do have symptoms, they're flu-like. They can cause meningeal irritation and muscle spasm. Flaccid, asymmetric paralysis. Flaccid paralysis we've talked about. You remember when we talked about flaccid paralysis? Remember, this is your floppy. So our floppy baby syndrome has a flaccid paralysis as well. Flaccid paralysis here is asymmetric. When we talked about it, it was symmetric. It was on both sides. Okay, so that's your differentiation between the flaccid paralysis. Typically affects proximal muscles of the lower extremities. With ours, botulism baby, the honey, it's descending. So it starts up and goes down. There's the difference. Between 2 and 10 out of 100 who have paralysis from polio virus infection die. Because the virus affects the muscles that help them breathe. So that sounds very similar to the botulism. When those respiratory muscles are no longer able to work, they just need some type of a mechanical vent. There is a post-poliomyelitis syndrome that can occur. This is a progressive muscle limb paresis with muscle atrophy and fasciculations and fibrillation during rest activity. So they may have some weakness of their muscles, and then they have these like twitches, these like little spasmy like twitches here and there when they're resting, they're not doing anything. This can appear 15 to 40 years after apparent full recovery. So the patient recovered from the virus, but then 15 to 40 years, here goes this muscle weakness and these fasciculations out of nowhere. It can cause permanent scarring of the muscles and leads to muscle wasting, weakness, and permanent disability. For this diagnosis, it is so important for you to get that travel history and immunization history. So again, back to your basics, back to basics. Getting a thorough history is super important in infectious disease. Travel history, immunization history. You might do an MRI. You possibly could do a stool culture for diagnosis using samples from the throat, urine, blood, or CSF. And then your differential is there. Acute flaccid myelitis, which is what that initial patient was diagnosed with until they found the polio, or he wasn't diagnosed, but he was admitted under the assumption that that's what it was. Guillain-Barré, which we also talked about, that also is from the bottom up, unlike our botulism, which is from the top down. West Nile, thick paralysis, and Japanese encephalitis are on the Guillain-Barré, usually weakness is more symmetric and ascending. Varices is more common. Treatment, anyone with suspected polio needs to be hospitalized. You're not for sure what it is, just like they treated him, they admitted him immediately. They weren't for sure until day 11 or 12, but hospitalized immediately, any person that you suspect might have polio. There's no cure or specific treatment for it. You just need to give supportive care. These patients might need PT, OT, rehab. You're going to definitely consult ID and neuro for this. Prevention, vaccine during childhood. Routine vaccination in adults is no longer recommended because of the low incidence of the disease. Again, we had 2 cases, 1979 and 2022. So they're not really recommending it, but you might need to, if they're planning to travel to an endemic area, or patients that are handled like stools, because remember the primary transmission is fecal oral. So patients that work in a lab doing stool cultures or something like that, maybe they need it, but typically it's not a routine vaccination for adults. These patients with the post-polio syndrome will likely need joint replacement. Professor G is going to talk about post-polio syndrome in more detail during her lecture on MSK. Globally, adults who are traveling to countries with increased risk of exposure to polio or who are unvaccinated should receive this series of 3 doses. So again, traveling and you're unvaccinated to one of these countries, you definitely want to consider the dose or consider the vaccine. I have two vaccine schedules posted for you to review. Just look over your schedules. You see COVID-19 up at the top. And you should be familiar with most of these. So you can just look at this and just be familiar with it. Try to remember those that are vaccine preventable. And we'll go from there. We're gonna do rabies and we'll finish up. Rabies is a viral rhabdovirus. Talk about rhabdovirus. It is a viral encephalitis transmitted by infected saliva that enters the body by an animal bite or an open wound. Rhabdovirus. Rabies sounds like rhabdo. So if you see rhabdovirus, you should be thinking rabies. It is a viral encephalitis transmitted by infected saliva that enters the body by an animal bite or an open wound. Common vectors, raccoons, bats, and skunks. Raccoons, bats, and skunks. I would also add fox to that. There was a rabies fox at my house when I lived in Annapolis a couple years ago. And he looks crazy. He's just like, I don't know, they just look different. They're not like your normal, like, oh, he's so cute. No, they look a little off. So the raccoons, bats, and skunks account for about 86% of cases. Bat bites might not always be recognized. Some other rabies animals, we talked about foxes, cats, cattle, and dogs. Dogs in the United States rarely transmit rabies, rarely. But they do account for a substantial number of cases worldwide. When I traveled to Swaziland for that rotation and I did my onboarding, they said, do not give out any pets, don't pet any dogs. There's a lot of dogs who just roam the streets. They were like, if you bit by an animal, here's the number for the US Embassy. We have to lift you out of here immediately. Any bites while you're here. So in some countries, dogs might be a problem. Here in the United States, more than likely not. But this, again, probably not anything you'll have to really worry about. If a patient presents with a dog bite, you're calling the health department. Health department's going to determine treatment. But some patients definitely need to be assessed. So again, raccoons, bats, and skunks. Raccoons, bats, and skunks. Again, bat bites might not be recognized, and there are some people who have just been in a bat vicinity that have been diagnosed. So just in the vicinity, bats carry a lot of weird stuff. See a bat, you stayed in a cabin over the weekend, you need to call the health department because you don't know. You don't know what it's doing. The virus travels via the nerves to the brain and it multiplies there. And then it migrates along the afferent nerves to the salivary glands. That's going to be important in a second. Most cases of rabies are usually in rural Africa and Asia. I forgot to mention that. So the incubation period could be years to 10 days to many years. Typically, it's about 3 to 7 weeks. Depending in part on the distance of the wound from the brain to the CNS, is when you might see it present. So the further away from the brain, it might take a little bit longer. The closer to the brain, dog bites you on your neck, you're in trouble. You're probably gonna die. It's universally fatal. The closer the wound is to the brain, the more trouble you're gonna be in. There is a prodromal syndrome. These patients typically have pain and paresthesia at the site of the bite, so it's gonna hurt at that area. It is also associated with fever, malaise, headache, nausea, and vomiting, so our general type of viral presentation. These patients are sensitive. Their skin is sensitive to changes in temperature and wind or air, and they may have percussion myoedema, sorry. And you can look at this if it'll play. So you hit it and look at that muscle come up. I don't know if this shows it. And then it raises up.
Ooh, yeah.
Really weird. Percussion myedema. If I saw that in the clinic, I'd be cool. Kind of crazy.
Take a reflex hammer.
Some patients
Like,
also
yeah,
like,
why do you think of me
present with
doing that?
abnormal sexual behavior. And that
Oh.
wasn't very clear on what that actually means, but Just use your imagination. I don't know. So the CNS stage begins about 10 days after the prodrome and may be either encephalitic or paralytic. Both forms progress to coma, autonomic nervous system dysfunction, and death. Again, rabies is universally fatal. If it gets to your brain, there's nothing that can be done. The encephalitic form, which is about 80% of the cases, produces classic rabies manifestations of delirium, alternating with periods of calm. So they're there, then they're very calm. Extremely painful laryngeal spasms on attempting drinking, hydrophobia, rhabdovirus, rabies, hydrophobia. This is when patients basically choke when they're trying to drink the water, they're choking, and they're sometimes scared even to try to get in the shower, they're afraid of water at that point. So that's an unusual symptom, but it is only seen typically with rabies, patients who have rabies. So hydrophobia, fear of drinking. Anatomic stimulation, so they might drool, hypersalivation, they could have seizures as well in that encephalitic form. In the less common paralytic form, they may have an acute ascending paralysis resembling Guillain-Barré syndrome. So now we've talked about those symptoms. We're going to take a look at a video.
Bless you.
Get that. Quantitative PCR, ACE testing, immunohistochemical test, and viral isolation from the patient's CSF. The CSF may show rabies, reverse transcriptase by PCR. MRI is usually non-specific. It might show non-enhancing, ill-defined things. It's usually non-specific. It's could be diffuse, so it might not be too helpful. So the follow-up. Biting animal that appeared well should be quarantined and observed for 10 days for bizarre behavior. So you want to basically quarantine that animal and see if it's acting crazy or rabies. Sick or dead animals should be tested for rabies. When the animal cannot be examined, say it was something wild in your backyard, you need to presume that it was rabies. Okay. It's also recommended that suspected animals be euthanized so that their brains can be tested for the virus, but if that was your pet, you might not necessarily want to euthanize it, but that is also something that they recommend so that they can test the brain of the animal. Treatment, like we said, no specific treatment available, especially once it gets into the brain. Management requires intensive care with attention to the airway, maintenance of oxygenation and control of seizures. Universal precautions are essential. Prevention, immunization of household dogs and cats, and active immunization of persons with significant exposure, like vets or someone who works at a vet clinic, is important in the prevention of rabies. You want to thoroughly clean that area. You want to debride it, repeat flushing of wounds with soap and water. Never, ever, 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 ever suture a wound that's from an animal bite. Wounds caused by animal bite should not be sutured. You do not want to close that up and leave it inside. So keep it open. Pre-exposure immunization. Immovax vaccine is what we use for that. This is recommended for persons at high risk. So we know that they're going to be at risk. Veterinarians. They should have their rabies antibody titers checked every 2 years, and they need to be boosted with 1 ml intramuscularly. People that handle animals, people that work in labs, Peace Corps workers, travelers with stays over a month to remote areas in endemic countries, Africa, Asia, Latin America. While they said, you're gonna be airlifted out of here if you get bit by an animal or a dog. So definitely those patients may need the vaccine, before traveling or for work purposes. Post-exposure, so after the bite. This is the most common ER visit for bite. Animal bites are the most common ER visit for bites. The decision to treat should be based on circumstances of the bite, including the extent and location of the wound, the biting animal, the history of prior vaccination, and the local epidemiology of rabies. So if your area has a high rate of that, those kind of things will help determine. Again, more than likely, you're gonna be contacting the health department, and they're gonna help you make a decision in terms of treatment. Any contact or suspected contact with a bat, skunk, or raccoon is usually deemed sufficient indication to warrant prophylaxis. So like we said, it might not show up for 3 to 7 weeks. The typical is 3 to 7 weeks. It can be 10 days to many years. But if you get bit, you have time to get that post-exposure vaccine. If you wait and you're like, I'm not gonna take care, I don't care, it's just a bite. It didn't really break the skin, it really didn't do much, I'm okay. And then 10 years later, here you come frothing at the mouth and scared of water, might be a problem. It's gonna be too late to treat it at that point. So definitely bites, should come in for evaluation, and then we can determine what we need to do for treatment. Consultation with the state and health local department is recommended. Post-exposure treatment, including both rabies, immunoglobulin, and vaccination, should be administered as promptly as possible when indicated. There are 2 vaccines containing inactivated rabies viruses that are licensed for active immunization and available for use in the United States. We want to treat as soon as we can. Post-exposure treatment, including both rabies, immunoglobulin, and vaccination, should be administered as quickly as possible. The immunoglobulin, sometimes if you are able to see the wound, you know, like, oh, it bit me on my thigh, then you can treat that area with the immunoglobulin antibodies as well, and then do the vaccination as a combination. Prognosis. If post-exposure prophylaxis is given exponentially before clinical signs develop, it is nearly 100% successful in preventing the disease. Post-exposure prophylaxis, if given swiftly, quickly, before any symptoms develop, 100% successful in preventing the disease. Once the symptoms have appeared, death is almost inevitable and usually occurs after about 7 days. That's because of the respiratory failure of those muscles. When to refer? Suspicion of rabies requires contact with public health personnel to initiate appropriate passive and active prophylaxis and observation of suspect cases. Any questions about rabies? Hopefully you'll never, ever, ever see that. There was I think I said the other day, there was a news thing about a rabies fox or a rabies something in Virginia just last week. So the animals are around, stay away from them. We're gonna do one question, then we're gonna finish up. A 4-year-old boy is brought to the pediatrician due to worsening weakness in his legs. According to his mother, the patient had a low-grade fever and several episodes of vomiting 2 weeks ago. They are from Pakistan and are currently visiting relatives in the United States. The patient is otherwise healthy and takes no medications. Temperature 37 degrees Celsius, 98 degrees Fahrenheit, pulse is 94, respirations are 9 per minute, blood pressure 100/74, O2 stat 95 on room air. Neurologic examination is notable for bilateral lower extremity weakness, greater on the left than the right, as well as atrophy of the proximal lower extremity musculature. His speech is noted to be slightly dysarthric. Which of the following best describes the organism and mechanism of transmission responsible for this patient's symptoms? A, foodborne transmission of a gram-negative rod. B, fecal oral transmission of a roundworm helminth parasite. C, respiratory secretions containing a double-stranded DNA virus. D, sexual transmission of a spirochete. Or E, fecal oral transmission of an RNA enterovirus. What's your best guess? E, yeah, E, fecal oral transmission of RNA enterovirus. This is polio. Remember, fecal oral transmission, causing that asymmetric paralysis. Even though he had bilateral lower extremity, he's from Pakistan, visiting family, he's got weakness. You definitely want to hospitalize him and treat as if it is until you can come up with your diagnosis. All right, more resources at the bottom if you need them. Thank you for signing Barbara Graham's card.